Hi, my name is Dean Giacobbe, and I'm an anesthesiologist from a large anesthesia practice in central New Jersey called Anesthesia Consultants of New Jersey. And I'm the medical director of the University Center for Ambulatory Surgery, which is a freestanding ambulatory surgery center designated specifically for orthopedic surgery. And at our center, we perform a full complement of orthopedic procedures, including spine and total joint replacement. And today I'm here to talk to you about our total joint replacement program. Just a couple words as an introduction in getting started. About 18 months ago, we began this project to start an outpatient total joint replacement specifically for knee and hip replacement. And at that time, there was really very little to guide us. There was few, if any, studies published in the medical literature, and I was aware of some other centers in the country that were also performing outpatient joint replacement, but there was really little discussion being had on protocols and exactly how to pull it off. To try to get started, there was another center in northern New Jersey that had a very robust outpatient program, and I went to their center and made arrangements to go there for a day. And after only being there for about an hour, I was asked to leave by the head nurse because apparently the chief surgeon said that he had figured out how to do this on his own, and that if I wanted to learn how, I'd have to figure it out myself. It's also recently come to my attention that there's another large East Coast program that has made their protocols proprietary. And I think both of these things really aren't in the spirit of the best of medicine. 10 years ago when I got started in running an acute pain service, really the great anesthesiologists that had gone before me, guys like Greg Hickman and Jim Bononis and Trip Buckenmeyer, were really just remarkably gracious in pouring out to me all their protocols and paperwork. And so it's in that spirit that I want to really share with you what we're doing. I make no claim that we have sort of the definitive protocol for doing outpatient joint replacement, but it's my hope that in sharing this, we generate a national discussion so that we can really forward the science of performing joint replacement on an outpatient basis. The one thing I had the good fortune of hearing last year in May at the ASRA meeting in Boston was one of the anesthesiologists from Rush in Chicago presented their experience with outpatient joint replacement. And while their program is very different than ours, I would sort of refer to it jokingly as Darwinian in that they're a hospital-based program so that all patients come in and are potential candidates for outpatient joint replacement, and if they meet certain criteria within a specified amount of time, they're discharged from the hospital to home. The remaining patients are admitted. Our program is very different from that in that we are freestanding, and so being admitted really isn't a feasible option, and so we had to approach our protocol differently. But that being said, I think the Rush program is fantastic, and I borrowed heavily from their anesthetic protocol for our hip replacement protocol, which I'll share with you today. What you'll see as I talk about this is that essentially any program that has a robust joint replacement service on an inpatient basis, there's really nothing magical here. There's nothing special that we're doing. If there's any magic at all, it really is in how we've put our system together and we've prepared sort of as a system and as a team. In beginning an outpatient joint program, I would liken it to stepping off a cliff. All joking aside, about 70% of the work really is in the preparation. When you begin to think about all the component parts of sending a patient home after a major joint replacement and think about the different things that are provided for these patients on an inpatient basis, you really realize that there's a tremendous amount to put together to provide those same services at home so that it's seamless and that their patients really aren't left without the support that they need. So I would say it's 70% preparation, 10% the recipe. There are no secrets here. I'm going to share with you our entire protocol, so I'm going to give you our recipe, and then the remaining 20% really is just in the courage to jump off the cliff. This is a bit of a daunting undertaking to start. I can tell you that the day we did our first case, everybody's nerves were on edge, and right before we were about to cut skin, the chief surgeon leaned over the drape at me, and he's a good friend, but he sort of said, smiling, "Listen, Dean, I'm doing the same thing today that I do every single day in the hospital. This entire thing is on you." And while that was daunting, I realized that it spoke to the importance of the anesthesiologist in pulling all this off. So that's where we are. There's been a lot of discussion in the anesthesia community recently about perioperative home. I really think this is one of the unique circumstances where we as anesthesiologists really can embrace the true meaning of the perioperative home, in that I as an anesthesiologist in our joint replacement program and involved from the very beginning of the patient's interaction with our system all the way through home and discharge and follow-up phone calls and that sort of thing. And one of the things that's going to be paramount in trying to start a program, if you're interested in doing that, was you really have to have somebody who is the quarterback, somebody like myself who's really willing to own this whole thing, have all the long meetings and interactions, and really the attention to detail that's going to allow this to be successful. Like I said earlier, if there is any magic in the process, it's that we've developed a tight protocol and a very, very comprehensive team. I think one of the things that we've done that's been incredibly important and successful is we very early on identified the concept of a coach. That is, each patient must specify a specific individual who will be their coach for the entire perioperative process. And so that person attends the preoperative appointments with the patient and all the consultation, and also makes a commitment actually in writing to be present for the first 72 hours post-operatively. And that has turned out to be vital because 4 ears and 2 brains certainly processes the enormous amount of information that comes at the patient much better. And also in moments of insecurity or in fear afterwards at home, I think it really helps to have an additional person there who really is involved and knows all the details in much the same way as a couple goes through the laboring experience. During our preoperative visit, we schedule these. It's about a half-a-day appointment for the patient and their coach. They first come in and they meet with our surgeon, and they go through all the preoperative evaluation and discussions with the surgeon, including signing the consent. And we'll come back to that in a minute, why that's so important, but we insist that that be done ahead of time. They then meet with our total joint coordinator, who gives them what we jokingly refer to as the book. It's a personalized book that I'll show you in a moment that goes through all the details of the entire procedure and process. They then come and meet with the physical therapists. And we have the good fortune that our entire facility is all housed in one building. So they start out on the first floor in the office space. They then proceed to the physical therapy. At physical therapy, the patient and the coach are taught the entire sort of protocol for postoperative care and movement. And specifically, they're assessed for their functionality with both crutches and a walker. And also, it's a chance for the physical therapist really to evaluate that team, that patient and coach, and their ability to function at home. I think one of the other strengths of our program is that in addition to having the coach, we've also kind of copied, if you will, the Toyota assembly line model, and that is that we empower every worker to essentially shut the assembly line down. And what I mean by that is if every team member has the right to sort of say that they don't think that this patient and coach are a good outpatient candidate, and they can automatically defer the case to being done on an inpatient basis without any sort of second thought. So for example, if you had a huge physical mismatch in the patient and coach, and you didn't think that the coach would be able to assist the patient at home, for example, getting off of a commode or from sitting, and the physical therapist didn't think it was in the patient's best interest, we empower the therapist to make that decision, and then we transfer the patient, and it's done on an inpatient basis. Once the patients are done with the physical therapist, they come and meet with me, and I'm as the anesthesiologist. I do a standard preoperative evaluation, physical exam. We also have a tremendous amount of teaching that goes on at that point. We talk in length about their personal medications, how to manage them in the perioperative period, how to include our perioperative multimodal analgesic with the medicines that they're already on. We talk about the anesthetic protocol and about our catheters and all that things, and go through all the teaching at length. And like we say, this is really a chance for us to be a perioperative physician and be involved in both this preoperative evaluation and the intraoperative management. So each patient is given what we jokingly refer to as the book. It is actually a 3-ring binder that's customized for each patient, so this is a fictitious example of what the cover of it would look like. And inside, the first page has all of the contact numbers for all the various parties included in this process. So the surgeon's daytime numbers, answering service numbers, the numbers to reach our acute pain service line, how to reach the home visiting nurses, home physical therapists, the transport company, etc. There's also extensive information in the book about preoperative preparation, so things like how to take the HIPAA-cleansed showers. There's a description of the procedure and the anesthetic protocols. And there's also a description of the multimodal analgesic regimen the patients are to take and how they're to do that. And each of these is provided to the patient on the day of their preoperative evaluation. This is just an example of our physical therapy space. While it's not the Andrews Institute, we're quite proud of it. And patients, this is where they're done with their initial preoperative physical therapy evaluation. On the night before surgery, the surgery center calls the patient just to confirm their arrival time and finalize any last-minute instructions. We as a practice, an anesthesia practice, have a policy that we call all patients the night before surgery. So says the anesthesiologist. I call the patients, and usually it's a very brief call just to see if they have any last-minute questions about either the medications to take or what's going to transpire the next morning. They take a HIPAA-cleansed shower at home that night, and they also take 200 milligrams of Celebrex PO. On the morning of surgery, the patients again repeat the HIPAA-cleansed shower. They take their multimodal analgesic regimen, which I'll discuss in just a moment. They arrive an hour and a half prior to their surgical time. Most of these are done as the first case of the day, so they arrive anywhere between 6 and 6:15 in the morning. And the beauty of with having such an extensive preoperative teaching and all these phone calls is that when the patients actually arrive on the day of surgery, there's very little in the way of discussion. We're immediately able to get the patients admitted, start an IV, and begin with our anesthetic treatment without lengthy discussions. They just sign the consent and we get going. Our oral pre-medication is probably similar to many centers are using both on an inpatient basis. They get Celebrex, 200 milligrams, Oxycontin, 20 milligrams, gabapentin, 600 milligrams. And when they arrive to the surgery center, we give them a single oral dose of aprepitant as an antiemetic. We elected to give that actually at the center just because of the cost. Each pill is about $40. And so as a courtesy to our patients, we give that at the center. One of the things you'll notice in this is that we use gabapentin. Our surgeons are comfortable with that and have used that for quite a while. Certainly, pregabalin would be a very reasonable alternative. So what is our protocol for the anesthetic specifically? So for total knees, we're doing a combination of a single-shot femoral block with a femoral catheter inserted at the same time, and that's done with 0.5% bupivacaine. We also do a single-shot subgluteal sciatic nerve block without a catheter, and again, that's also 0.5% bupivacaine. And then we run them with a femoral catheter postoperatively for 3 days. In the OR, the patients have a light general anesthetic with an LMA and an inhaled volatile anesthetic, and we titrate it to a BIS monitor, again, to try to minimize the amount of anesthetic that's delivered because the blocks are doing the lion's share of the work, if you will, and to really speed recovery and discharge. Our hips are all performed on the outpatient basis. The surgeons are using an anterior approach. And our protocol for that, again, as I mentioned earlier, I largely borrowed from the folks at Rush. I had thought long and hard about the best possible protocol to do this. And I was interested, because of the nature of the center that we are, trying to use a regional anesthetic technique and abandoned very quickly the idea of a spinal anesthetic because I wanted to avoid the TNS associated with lidocaine and wasn't willing to have the long discharge time and the potential urinary retention associated with a bupivacaine spinal. So we've elected to go with a lidocaine epidural. Those are placed preoperatively. On the way to the operating room, we begin dosing them. They usually additionally get a bolus of about 20 milliliters of 2% lidocaine. And then we sedate the patients with propofol as an intravenous infusion during the case. The combination of the propofol for sedation and the lidocaine epidural generally makes these patients moderately hypotensive. Our principal joint surgeon trained at the Hospital for Special Surgery in New York, which began the whole hypotensive anesthesia process, and so he's quite happy to have them be hypotensive. And so as long as the patient has no comorbidities, we allow their means to drift down to somewhere into about 60-65 range. The truth of the matter is the anterior total hip is such an elegant operation and the pain is so minimal that it probably doesn't really matter what kind of anesthetic you do. You could probably just as easily do a general anesthetic, but again, we've really come to love the lidocaine epidurals and find it just to be a very elegant way to do the anesthesia. In the OR, each patient gets 2 doses of tranexamic acid, and that's for both the hips and the knees. They also obviously get antibiotics. We try very, very aggressively to keep the patients warm with forced air warmers, et cetera. And about 45 minutes before the end of the case, patients get 1 gram of IV acetaminophen, IV piggyback. And they also, at the time of closure, get a second dose of tranexamic acid. This is largely borrowed from a study out of Japan. And so for our hips, the gram both at incision and before closure is given IV piggyback. For the knees, the initial dose is IV piggyback, but then at the end, the gram is actually infiltrated in the wound. We also, and perhaps it's overkill, but we also give a dose of IV dexamethasone and ondansetron in the OR, again, just for antiemesis. And while it's probably a potential source of criticism of our protocol, we just thought with patients taking potent opioids orally for the first time, we thought the risks of being nauseous at home certainly were outweighed by and the advantage of really being very aggressive in our antiemetic protocol. At the time of closure, the surgeons inject a cocktail, if you will, into the joint capsule and into the wound. This whole cocktail is diluted into a 60 milliliter syringe, and it's composed of 20 milliliters of 0.5% bupivacaine with epinephrine, 40 milligrams of methylprednisolone, a gram of cefazolin, and then diluted out to 60 mLs with normal saline. In our recovery room, none of these patients have drains placed, which simplifies the recovery room process. I know that there's other outpatient joint centers that do have drain placement and have various protocols for how to remove the drains in the operating room. We don't do that. We use the OnQ C-block catheter pump for our femoral catheters for the total knees. That's connected in the recovery room. Once the patient meets phase 2 status, they are reevaluated by our physical therapist. So one of our physical therapists comes up from the physical therapy space and just ensures that once the patient actually now has an insensate limb or has had their hip replacement, that they're comfortable ambulating with either the crutches and the walker and that they're safe for discharge. The knees have a knee immobilizer placed on them, and we emphasize repeatedly with the patient and the coach that that has to remain continuously in place for the first 72 hours while they have the femoral catheter in place. We think this is paramount to avoid falls, and obviously falls are one of the great fears that we have. Luckily, to date, we have had none, and I think it's because we emphasize keeping the knee immobilizer on 24/7 for 72 hours and make such an emphasis against about falling. The patients also undergo extensive postoperative teaching with their coach in terms of how to reach us through the answering service for the acute pain line, how to manage the catheter, how to manage the wound. Our surgeons use something called an Iceman, which is an infiltrative cooling device, how to operate that at home. And then just prior to their IV being removed, they're given a second dose of antibiotic, and then they are discharged. Patients are all transported from our center to home via Ambulette. We use a private ambulance company, and they provide 2 attendants, and the attendants essentially ensure that the patients safely get into their house and get situated. We recommend to the patients that they plan to spend the first few days at home on a single level of their home to simplify ambulation. Most of them share with us that within about 24 hours they're all over the house, but that's our advice to them. On the first morning of postoperative day 1, they're seen by a visiting nurse, and they get a second visiting nurse visit the following week. On postoperative day 1, they also get their first at-home visit from physical therapy, and the physical therapist sees them for the first 10 days at home each day postoperatively. When we set up this process, we met individually with the Visiting Nurses Association and all the physical therapists, and again, this is what I'm talking about in terms of a really tight process and protocol. We met with all the individuals involved so that there are no surprises, and so they're very clear on what our expectations were for their care of our patients at home. The patients receive daily calls from the surgery center specifically to evaluate them in terms of pain and how they're doing, and we record that on a log, and we talk to them about managing their catheter. Also, if the patients have after-hours questions about the nerve blocks or catheters, we have an answering service, and I would strongly recommend. We actually tried a couple of different services unsuccessfully, and then we were fortunate enough to come across an answering service that is called On Call Central. It's a web-based answering service that's phenomenal, and that's what we use for our answering service. Patients call us. If they call after hours, the anesthesiologist on call receives a text message, and embedded in that text is the patient's phone number and then also the number for the answering service. So when you receive those text messages, we just tap on the number for the answering service. It plays back to us the message that the patient has left, and then we can hit an additional digit and it will dial the patient back. When it calls the patient back, your personal cell phone is blocked, and what appears in their caller ID is the answering service phone number, and it also tape records the entire conversation you have with the patient, which is wonderful for us from both a quality assurance perspective, and we can review how our physicians are interacting with the patients, and also from a medical legal perspective. Patients are also receiving, in terms of anticoagulation, they get aspirin. They take 325 milligrams twice a day, and they take that for the first 4 weeks postoperatively. One of the things that is a reasonable question to ask is, a standalone surgery center, we were wondering when we initially set this up is, what would our plan B be? What if a patient actually wasn't discharge capable at the time of operation despite all of our preoperative evaluation and assessment? So we've established a relationship with 2 local rehabilitation facilities, and that essentially serves as our plan B. So that if a patient were not capable to be discharged from the center home safely, we would then have them transported by ambulette to the inpatient rehab facility. Fortunately, to date, we have not yet exercised that option. However, we give the patients the option. So we've had one patient out of our approximately mid-20s-ish number so far who was a single mother who said for her it would be easier to not go home and try to care for her children. So she elected to go and have her procedure done on an outpatient basis and then was transported to the inpatient rehab facility. One of the caveats of this, just to be aware of, is again, this is a relationship you'll have to establish ahead of time, because insurance companies, at least in our area, will not cover for these until the postoperatively. So for example, in the case of the patient who elected to go to the rehabilitation facility, we had preoperatively made arrangements with the facility, but we couldn't actually get insurance approval to have the patient admitted until postoperatively. So again, we have an informal working relationship with these facilities, and so prior to doing a total joint replacement, we call them and we ensure that they have a bed waiting for us should we need it. So to date, we've done approximately about 25 outpatient joint replacements. While it's not an enormous number, it's been quite successful, and I wanted to share with you a little bit of our data. This is a bar graph depicting our average length of stay at the surgery center, our operative times, and our recovery times. If you look at the column on the left, those are essentially door-to-door times. And what you'll see is that our average is that patients spend approximately 6 to 6.5 hours in our center. What does that mean for us as a center? It means that we've chosen to do all of these cases in the morning so that there's plenty of time to get the patients ready for discharge. What we've also realized is we switched transport companies, because what we found was that some of that recovery time was in the fact that patients had already met discharge criteria, and they were spending an additional 45 to 60 minutes waiting for the ambulance company to bring them home. What problems have we had to date, or complications, if you will? We've really been quite fortunate. Our very first patient had a fairly sizable hemarthrosis of his knee, and so in the surgeon's office on postoperative day, I believe it was 2 or 3, that was aspirated. And at that time, the surgeon was using rivaroxaban as an anticoagulant, and at that time is when we made the decision to switch over to oral aspirin. We've had no thrombotic complications, and again, have had no other hemarthroses. We had one catheter for a total knee replacement that suddenly was working quite well, and at 48 hours stopped functioning. The patient reported that he'd been walking and the catheter got caught on something. When he came in and we evaluated it, it didn't seem to be dislodged. He elected not to have the catheter replaced and was moderately uncomfortable, but we were able to change his oral analgesic regimen, and he did quite fine after that. The other patient to report is we had a single patient who on postoperative day 2 was undergoing physical therapy and passive range of motion, and the upper portion of the knee wound opened, and there was a little bit of bleeding, so the patient went to the surgeon's office. He put a compression bandage on the wound, brought the patient to the hospital that evening, irrigated the wound, reclosed it, and because they finished at a late hour, the patient elected to spend the night. So on postoperative day 2, he spent 1 night in the hospital and then returned home and has done quite well. As I reported earlier, also we have had no falls to date, and I think that's a function of all of our pre-op teaching, and particularly with the knees insisting that they wear the knee immobilizer continuously for 3 days. I think the question that you need to ask yourself if you're interested in starting one of these programs is, will what we've done work for you? And I think I'm eager to hear feedback from the audience in terms of modifications to this protocol or improvements that people have tried and seen. There are some things that are unique about our center that might not necessarily extrapolate to yours. For example, we're blessed with having all of our resources in one building. So physical therapists, x-ray technicians, et cetera, are all in one space, and so it's quite easy for us to evaluate these people both preoperatively and postoperatively. We were also an out-of-network center, and so the finances of this might not be feasible for you. And obviously, we've seen tremendous variation in this across the country, and so it's something you'll have to work with your payers on. The other thing I think that's really quite important is, do you have the buy-in of all the various team members? Obviously, you need a surgeon who's very engaged in this, but also the ancillary support like the nursing staff, block nurses, home physical therapy, et cetera. And lastly is, do you have somebody who can really serve as the champion for this? One of the things that became very apparent after we did this is, as I discussed earlier, there's an enormous amount of legwork to assemble all the various parties and really pull this off repeatedly in a very cohesive and sort of tight manner. And you need to have somebody who has enough political clout within your institution and environment to really sort of champion this and lead it. I'm not saying it has to be specifically an anesthesiologist, although I think that would be wonderful. But you need somebody who can really kind of champion this and get everybody engaged. Where are we interested in going forward? As a center ourselves, we're in the process right now of doing a very comprehensive financial evaluation. We believe that we're doing these at approximately 60% of the cost of doing them on an inpatient. And so we're trying very hard to get a seat at the table with our insurers and to discuss this. We're also quite interested, there are currently no outpatient codes for ankle replacement or shoulder replacement, and we're interested in adding those to our repertoire. Just a final couple of thoughts on team development. I think it's very important that you have a very comprehensive team put together beforehand. I think the idea of having a patient coach be assigned is very important. I think each team member needs to be empowered that if they get sort of that sixth sense that things aren't quite right, that they're empowered to insist that the patient be done on an inpatient basis without a lot of pressure and pushback from either the surgeon or the anesthesiologist. I think you as a team need to collect data going forward, and I think you need to meet periodically to review your progress and your process and see if there's room for improvement. And that if you are in a situation where the patient and the coach aren't fully engaged, you cancel the procedure and transfer the care to an inpatient setting. And I'm going to leave you with one final story. We had a patient who, for various reasons, came to his preoperative appointments without his coach. And at first, it sort of seemed he was very easily able to explain it away. We all became very concerned, however, when he showed up for his physical therapy appointment without his coach, insisted that they come back together and have that, so they did. But everyone's sense over time growing was that there was a disharmony, if you will, in this couple. It was a married couple. And actually on the day of surgery, the patient showed up without his coach. We called her, she was at work. She had no intention of being home when he got home. And so despite it being very disappointing and having all the legwork that went into it, we elected to cancel that procedure, which I think was the right decision. And the patient was done approximately a week later as an inpatient quite successfully. So I think that this really spoke to our process, our commitment to doing this in a safe, effective way. And I wish you all the best of luck if you do decide to proceed with this endeavor, and look forward to hearing your feedback, because I'd love to hear other people's thoughts so that maybe perhaps our own protocol can be enhanced and developed. Thank you.